Good morning, everybody. Thanks for coming out to Grand Rounds today. To introduce our speaker today, I'd like to invite Dr. Randy Holcomb.
Hey, everybody. Good morning. Really my pleasure this morning to introduce Dr. James Gerson, who's going to give our Department of Medicine Grand Rounds. James got his medical degree at Case Western Reserve University School of Medicine, and then did internship and residency in internal medicine at Stanford. Came back to the East Coast to do a hematology oncology fellowship at Fox Chase Cancer Center outside of Philadelphia. He then went to the University of Pennsylvania and the Abramson Cancer Center as assistant professor in the lymphoma program, where he took care of patients with all sorts of lymphomas and got tremendous experience in CAR T cells, which you're going to hear about today. He's had numerous peer-reviewed publications, most of them really focused on lymphoma, especially mantle cell lymphoma and CAR T cellular therapy. And he's going to talk to us today about chimeric antigen receptor T cell therapy, engineering the immune system to cure cancer. James.
Thank you, Dr. Holcomb. I'm going to go mask off for this. It's a little easier for me to talk. And thank you, Dr. Dixon and the Department of Medicine for having me today. It's really a pleasure for me to be here. I came on the faculty at the end of September, so it's only been 3 months. I still feel very new to Vermont and University of Vermont. Although my wife told me the other day that I sound like a true Vermonter because I've been complaining there's not enough snow for January. So hopefully we'll get some today. I wore my boots with my suit, which I've never done before. So I'm here today to talk to you about chimeric antigen receptor T cell therapy, which is a phenomenally exciting new therapy, relatively new, a little less new than it used to be, that has come to oncology and really has transformed the care of lymphoma and hopefully will someday transform the care of solid tumor as well. These are my disclosures, really just one. Ran a clinical trial at University of Pennsylvania funded by Loxo. So I have 3 objectives today. The first is to tell you about CAR T, the history behind it, because it's a fascinating history leading to FDA approval for a number of different constructs and indications. Discuss the benefits of therapy and also the potential side effects. And the side effects I'm going to focus a lot on because many of the listeners and attendees today will manage these patients as consultants, even as primary when they're in the intensive care unit. And so I'm really hoping that this will be educational and teach you what you need to know and what's most relevant when you care for these patients. And then lastly, outline the logistics of treating patients under the new program. So we are not yet open to treat patients, but it's coming very soon. And I'm really excited how close we are. And so I'll take you through that timeline so you know what to expect. And I'll start with a case. This was a woman who I cared for a number of years at the University of Pennsylvania. She was 56 years old when I met her, and she had been diagnosed with follicular lymphoma that eventually transformed to diffuse large B-cell lymphoma and had had a number of treatments over the course of her life, in fact, 10 of them, which are listed here. And unfortunately, she had very refractory disease. And in July of 2021, this was a PET scan showing some representative images, really bulky disease in the right axilla, a lot of disease in the abdomen and pelvis as well. And I'll come back to this case at the end of the talk to hopefully show you what we can do with CAR T. But I want to start by giving you some history because, again, this is a really fascinating story. And to start and set some baseline, I want to just mention back to your immunology days from medical school, which a lot of you, I'm sure, haven't thought about in quite a long time, which is to discuss the role of T cells in the body, specifically CD8-positive cytotoxic T cells. So when you're infected with a virus, the viral particles infect normal cells and hijack those cells and turn them into a factory to produce more virus. And so a cytotoxic CD8-positive T cell, its job is to come in, engage with an infected cell, and induce apoptosis through a variety of mechanisms to really stem the tide of the infection. And the T cells are really the main way that we get over a viral infection. And so in cell therapy, we use this same mechanism, except we direct the T cell against the cancer cell. And it turns out T cells are very apt to destroy a wide variety of cancer cells, not all, but many. And so we instead use a T cell to engage with a cancer cell and to induce apoptosis of that cancer cell. This is not a new idea. And so cell therapy has been along for 60 plus years. And so the first description of this was in a mouse model in the 1950s, where a mouse with leukemia was cured with an allogeneic transplant from another mouse. And it wasn't really understood how this worked until more like the 1970s, 1980s, when this was moved into humans, and it was discovered that it was modulated by the graft versus leukemia effect by donor T cells. And so chemotherapy is often given as a part of a stem cell transplant, but it has very little impact on the cancer itself. And really, the way that patients are cured when they have bad leukemia is by using the new immune system, and specifically the donor T cells, to target and kill the leukemia. Allogeneic transplant remains a standard practice for many leukemias, some other lymphomas as well, but mostly leukemia in today's world. There's some other cellular therapies as well in the solid cancer world. And so CIP-T, which is autologous derived T cells that are cultured with a prostate antigen, has been used in prostate cancer. It's really fallen out of favor, not curative, and the responses weren't dramatic. And so I'm not a prostate cancer specialist, but it's not really used that much anymore. And high-dose IL-2 has been used for many, many years in the treatment of advanced melanoma and renal cell carcinoma. And this is not infusing T cells, instead just giving an agent to induce the T cells to target the cancer. Again, not really used much anymore because of the toxicity profile, but sort of set the basis for a lot of what we understand about the immune system in targeting cancer. And high-dose IL-2 is really sort of what led to checkpoint inhibitors in solid cancer as well. And so what's special about CAR-T if using the immune system is not new? CAR-T is not just removing T cells and reinfusing them, but actually using genetic modification to change the code of the T cells so that they actually target the cancer in a very special way. And so this schema and animation, which was put together by my colleague at UPenn, David Porter, which I'll start in a minute, really shows you exactly what happens here. So the T cells are genetically modified using either a lentiviral or a retroviral vector. And the first CAR T cells were targeted against CD19, which is expressed ubiquitously on lymphoma cells as well as normal B cells. And so the transfection induces a chimeric antigen receptor, which combines an antigen recognition domain with an intracellular signaling domain to create a chimeric protein on the surface of the T cell. So this is the animation. So the lentiviral vector goes into the T cell and creates this new CAR T receptor. It's trafficked to the cell surface, and in this case, it's anti-CD19. And this allows the T cell to engage with CD19 on the surface of a lymphoma cell and induce apoptosis to kill the cell. And a big piece of this is not just the CAR itself, but also what's called a co-stimulatory domain. And some of the early work with CAR was very disappointing because the cells just didn't persist and expand in the body. And it wasn't until the discovery of the co-stimulatory domain and the importance of this that this therapy really moved forward. And so this allows for not just one signal for the T cell to survive and persist through the T cell receptor, but also a second signal that really gives a strong survival stimulus and proliferation stimulus to the T cell. And these cells now have been shown to persist for many, many years after a single infusion of therapy. So the longest experience actually is about 10 years after a CAR T infusion, where at very low levels, the T cells are still detectable in the blood. There's two main routes of co-stimulation. One is CD28 and one was 401BB. I don't want to harp on this too much because it's probably over the majority of the audience's head, but I will come back to this a little bit so there is some relevance. And what about the history of the CAR itself? So in the 1970s, adoptive tree cell transfer was first utilized, and that's taking T cells out of a donor and putting them into somebody else for some therapeutic effect. In 1992 was the first time a lentiviral vector was used to modify T cells. And then Carl June, who really is the original discoverer of a true CAR molecule and a CAR T cell, was initially studying T cells as the treatment for HIV. But in the late 1990s, he was recruited to the University of Pennsylvania. And again, the discovery of the co-stimulatory domain, that was really what led to success in the CAR T cell story. And through a lot of research in his lab, he eventually opened the first clinical trial in 2010 at the University of Pennsylvania. This is another fascinating story that I'll spend a couple minutes on, which is the first in human experience of CAR T cells. So Bill Ludwig was the first patient to receive a CAR T cell. He has gone public with his story, so this is not a HIPAA violation. He served as a Marine in Cuba during the Cuban Missile Crisis and was diagnosed with CLL in 2000. He had multiple lines of therapy between 2000 and 2009 under the direction of Alison Lauren, who was his oncologist at UPenn. In 2010, he was basically at the end of the road. He had very few options left and had pretty bad disease. And so he elected to enroll in this brand new clinical trial using CAR T-cell directed against CD19. The trial was led by Carl June as the research person, but also David Porter was the clinical person. So David Porter took over his care. He was the first patient to receive CAR T. He was admitted for lymphodepleting chemotherapy on his wedding anniversary. He developed severe cytokine release syndrome, or CRS, which I'll spend a lot of time on in a couple slides. But amazingly, 1 month after the infusion of the CAR T cells, his bone marrow biopsy was negative for leukemia. And 11 years later, he was still in remission, although he did require monthly IVIG because of persistent B-cell aplasia. That's him with his wife and I think granddaughter. So this was written up in the New England Journal of Medicine back in 2011, showing this experience of the single patient and the CAR T-cell infusion. And so on the left panel is his bone marrow biopsy at baseline with a dense infiltrate by CLL. The middle panel is about day 23. There looks visually from this distance like there's a lot of T-cell infiltrate. There's a lot of lymphoid infiltrate. You might think that's CLL, but it turned out that was all the CAR T cells. And then 6 months later was really a normal bone marrow. So the second trial that was started at the University of Pennsylvania was in pediatric ALL. And this is also another fascinating story that really set the stage for a lot of the ways that we mitigate the toxicity of CAR T. And so the first child to receive CAR T cell therapy was Emily Whitehead, who has also gone public with her story. She was diagnosed with ALL in 2010 at age 5. She unfortunately had multiple relapses. And in April of 2012, with very few other options, she enrolled in this new CART-19 clinical trial at the Children's Hospital of Philadelphia. And she remains in remission, and she takes these annual pictures on the anniversary of the T-cell infusion. I think she's at 10 years now, but I didn't update this to include her 10-year picture. And so she started this foundation as well. Really an amazing story of a girl who otherwise probably wouldn't be alive, really just getting her life back. Her story was also published in the New England Journal of Medicine with a second patient who received CART-19 on the same clinical trial. Both of them had no detectable leukemia 1 month after the infusion of the CAR T cells. Unfortunately, the second patient did relapse 2 months, so I guess a month after that, the bone marrow biopsy showing that the leukemia was gone, which was unfortunately an early indication that not all patients were going to have good outcomes with this therapy. All right, so how do we move from first in human to actual FDA approval? And so I want to take you through some of the data and the landmark clinical trials that led to these FDA approvals in 3 different disease sites, all blood cancers: leukemia, both pediatric and adult lymphoma, and multiple myeloma. And to set the stage for these approvals, I want to show you 2 studies that just document the very poor outcome for patients with relapsed and refractory diffuse large B-cell lymphoma and also pediatric ALL. So on the left is the SCHOLAR-1 trial, which was published a number of years ago, which showed that patients who have relapsed and refractory large cell lymphoma prior to CAR T had a dismal outcome, with about 20% of them expected to have any chance of a long-term remission. Pediatric ALL, a little bit better, but not much so, about 50%. And so the first trial to report out and be published leading to an FDA approval was the Eliana trial. And this studied one of the first CAR T-cell constructs, tisagenlecleucel, in pediatric ALL. I've heard it said that oncologists really specialize in saying long, difficult to pronounce words and just let it roll off your tongue. So a lot of practicing in front of the mirror. So this treated 75 patients with relapsed and refractory pediatric ALL with tisagenlecleucel, and they demonstrated an 82% remission rate, with many of these patients having sustained remissions, as well as persistence of CAR T cells years after. This trial is a little bit hard to interpret in terms of the long-term outcomes because most of these patients went on to receive an allogeneic transplant, sometimes their second allogeneic transplant. And so many of these patients, the CAR T cells were actually donor-derived from that first stem cell transplant. But there were a number of patients who did not get a second transplant for a variety of reasons. And many of them still had sustained remissions, although there were some relapses. So in August 2017, based on this data, the FDA approved Tisa-cel for the treatment of pediatric ALL with an age cap less than 25. So there were some young adults who could be treated with this therapy, but for the package insert, no one older than 25. And on the day of the approval, there was a flash mob in the Abraham Cancer Center, really just demonstrating all the hard work that had gone into this product. Because Tisa-cel was what came out of Carl June's lab, subsequently bought by Novartis. Moving on to diffuse large B-cell lymphoma. So the ZUMA-1 trial was the first trial to report out. This used a different construct, axicabtagene ciloleucel, as third-line treatment for relapsed refractory large cell lymphoma. 101 patients were treated, and they demonstrated a 54% complete response rate. Similar trial, tisagenlecleucel, which was again the construct coming out of University of Pennsylvania and also used in the Aliada trial. So the Juliet trial used that same construct, again in third-line large cell lymphoma, demonstrating a very similar 40% complete response rate. And so based on these two trials, the FDA approved both of these constructs in the treatment of large cell lymphoma in the third-line setting. And amazingly, with long-term follow-up, so this is now 4 years out from the Juliet trial, a large percentage of these patients remain in remission with no further therapy after a single infusion of CAR-19 cells. And we don't know. I still tell my patients, I can't promise this is curative, but this is a pretty good indication that a lot of these patients will be cured with this therapy.
I just took them out.
So next is the ZUMA-2 trial, which looked at a different lymphoma, mantle cell lymphoma, which is also an aggressive lymphoma that has a pretty poor outcome in the relapse setting, using a third construct, brexacabtagene autoleucel. This treated 74 patients with relapsed and refractory mantle cell lymphoma and demonstrated an amazing 67% complete response rate and a 90% overall response rate. Again, a lot of these, based on this plateau in the curve, looking like they're going to be durable remissions, potentially cures. And what's amazing here is that mantle cell lymphoma, otherwise previously thought to be an incurable lymphoma, unlike large cell lymphoma. And so to have an option that might be curing patients is really unprecedented. So based on this, in July of 2020, the FDA approved Brexacel for mantle cell. The next disease site study was indolent lymphomas, follicular and marginal zone lymphoma. So the ZUMA-5 trial again used axicel for the treatment of 125 patients with either of those histologies. 125 with follicular and 35 with marginal zone, so about 150, and demonstrated an 80% complete response rate, 93% overall response rate. Again, plateaus in the curve suggesting that once again, for previously thought to be incurable malignancies, we might now have a curative option. And so axicel and also Tisa-cel, based on some data that I didn't go through, are both approved for follicular lymphoma. And finally, the last hematologic malignancy to have an FDA-approved construct is multiple myeloma. So the KarMMa trial studied idacaptagene vicleucel, which is a slightly different construct. This targets BCMA. CD19 is expressed ubiquitously on lymphoid cells, but at their terminal differentiation, plasma cells lose their CD19 expression, so CD19 CAR doesn't really work. So this is a different target that does seem to be a very appropriate one. And so 140 patients were treated, 33% complete response rate with a 73% overall response rate. For reasons we don't quite understand, these responses don't seem to be as durable as they are in lymphoma. I'm still trying to work out exactly why that is. And so there's two constructs now FDA approved for multiple myeloma. Cilta-cel is the other one. And data I didn't show, Brexacel has been approved for adult acute leukemia, lymphoblastic leukemia. In contrast, Tisa-cel is only approved up to age 25. So we do now have an option for adults with acute lymphoblastic leukemia as well. And a very exciting update that came relatively recently. The drug development in oncology goes pretty standardly in late line therapy, patients who have very few other options. And then when we see a benefit, we start to move it up further and further. And so this is the first randomized phase 3 trial in the second line setting. Prior to this, the standard of care was for patients with relapsed large cell lymphoma was to take them to an autologous stem cell transplant, but outcomes really weren't fantastic. And so it was ripe for a change. And so this is a randomized phase 3 trial comparing CAR T versus the standard salvage chemotherapy and auto transplant, showing about a doubling of the event-free survival and response rate. And so this is now FDA approved in the second line setting for large cell lymphoma and has really completely transformed the field. We're now moving a lot away from autologous stem cell transplant. So this is the world as we currently stand. I like to tell my patients that oncology is moving at a mile a minute, so this is probably going to change relatively soon. But right now, there are 6 FDA-approved constructs for 3 different hematologic cancers, and the leukemia is both children and adults. All right, so hopefully I've convinced you that CAR T induces unprecedented results and potential cure in relapsed blood cancers. But at what cost? And so what are the side effects? And there's unfortunately no free lunch. And these therapies, though they have dramatic responses, can also have dramatic toxicity. And so I'm going to take you through 6 of the reported toxicities that are sort of more common in clinical practice and focus on the first 2 because they are the ones that, again, will probably be most relevant for the non-oncology providers, as you may encounter these patients on the floor in the ICU and have to be aware of these 2 major ones. So advanced thank you to the intensive care unit, neuro-oncology, the emergency room, the house staff, and nursing to help manage all of these. So the most famous one is called cytokine release syndrome, also referred to as CRS. This is a profound inflammatory reaction which manifests as fevers, hypotension, tachycardia. So I guess you could say it's just like SIRS, except it's mediated in a very special way by IL-6 from the expanding CAR cells. It has nothing to do with infection, although certainly a patient could be infected and it could look like CRS. But the vast majority of patients who develop this, it's just because of the cytokines. It has nothing to do with infection. It occurs at peak T cell expansion, which is hard to predict, but generally between day 3 and day 7. It's very rare after about day 30, but anecdotally, there have been some reports of that. And if you can send a multiplex cytokine panel, which I did routinely at Penn, probably wasted a lot of money, you find that IL-6 is preferentially elevated in comparison to the other cytokines. But we discovered that ferritin and CRP are pretty good surrogates for those. So since I don't think we have the ability to send IL-6 here or a multiplex cytokine panel, you can get away with just sending ferritin and CRP daily. So how is this managed? So we certainly check ferritin and CRP pretty regularly, as a rise kind of can tell you what's brewing. All patients, when they develop fevers, of course, should get an infectious workup, and this should include viral illnesses because that's not uncommonly a cause in patients who are immunosuppressed or have B-cell aplasia. They should all get antibiotics. I did tell you that it's usually not sepsis, but if 1 out of 10 times it is, you might as well give them antibiotics. But really, the ways to turn this around and the antidote, if you will, is a combination of steroids and tocilizumab. Tocilizumab is probably the preferred agent, as this targets IL-6 directly. And I'll take you back to Emily Whitehead because, again, the history of this is quite fascinating. So Carl June has this fascinating TED Talk, which I have linked here if anybody's curious. It's a really, really good talk. And he tells the story of how they gave this therapy to this young girl, and she almost immediately went into the unit with severe cytokine release syndrome, Tmax of 106, and she went into a coma. And the story he tells that he was standing at her bedside, what do I do for this poor girl? And he happened to know about tocilizumab because his daughter has juvenile rheumatoid arthritis. And I guess tocilizumab had recently been FDA approved as a treatment for juvenile rheumatoid arthritis. And being any normal physician father, he read up on it since she might need it someday and knew that it was IL-6. And they had sent all these cytokine panels and they saw that the IL-6 was really elevated. So he just had this idea, what if we try tocilizumab? And so they obtained emergency IRB approval to give her tocilizumab. They gave it to her and she had rapid improvement in hours. And so this is the fever curve of a different patient enrolled on the CTL-019 trial. And so this is over the course of days. And the patient was just continually spiking fevers up to 102, 103. They administered tocilizumab on day 10, and the fevers, again, almost immediately resolve and do not return. The rates of CRS are a little hard to pin down because they vary based on product. If you remember back to that co-stimulatory domain slide where I told you it was relevant, this is where it's relevant. And we do see much higher rates of cytokine release syndrome with the CD28 co-stimulatory domain. It probably has something to do with the rate of expansion. You see a much faster rate with the CD28 co-stimulation. And so the ZUMA-1 trial, which used Axicell, which is the only CD28 co-stimulatory domain product to be out there, you can see rates that are much, much higher as compared to Tisacell and Lisacell, which are both 4-1BB. And so early on in the course of giving CAR T cell therapy, there was a lot of theoretical concern that if you gave someone tocilizumab or steroids, that you would completely wipe out the T cells. And though you might treat the toxicity, you then completely negate the therapy you just gave them to try to cure their cancer. And so we were very hesitant to give steroids and tocilizumab. And so we really waited for patients to get very sick, really grade 3, grade 4. And so most of the time patients were in the unit and then they were getting these therapies and we really felt like we had no other options. But thankfully, one of the companies, Kite, opened this separate cohort 6 of the ZUMA-1 trial to look at prophylactic steroids as well as early tocilizumab. It makes sense since their product had the higher rates, so they were appropriately concerned about it. And they demonstrated that if you give dexamethasone 10 milligrams day 0, 1, 2, tocilizumab for grade 1 CRS rather than waiting for grade 3 or grade 4, and prophylactic Keppra, which will be more relevant for the neurotoxicity, which I'll get to in a minute, that you dramatically decrease the rates of CRS. So the overall CRS rates didn't seem to change that much, 94% to 80%. That's for any grade, so grade 1, grade 2. But the grade 3 to 5, 5 being a death from toxicity, dropped from 13% to 0%. So really no grade 3 to 5. And so this makes this product obviously a lot safer. But the most important thing to come out of this was they showed their survival curves, and the outcomes are nearly superimposable on the original ZUMA-1 trial. And this really gave us the information that it was safe to give these medications, that you were not going to affect the T cell function. And so now we basically give these very early, and so patients don't get that sick. And I used to tell patients it was about a 1 in 3 chance they would go to the unit, and now it's maybe 1 in 10, if that. Patients really do a lot better with prophylactic measures. So the second major toxicity, which some of you may see in the hospital, is I don't know who came up with this name, but it's immune effector cell associated neurotoxicity syndrome, also termed ICANS. We used to just call it neurotoxicity, and then someone came up with a fancy name. Now we're stuck with it. So this is a syndrome that can range with a variety of symptoms, from confusion to altered mental status to even seizures and persistent coma. There was a famous story of a patient at Penn who lived in the hospital in a coma for months after CAR T cell therapy. Has much more variable timing. It can be as early as day 2, as late as day 14, and usually not later, unlike CRS, which can occur late sometimes. It typically occurs independent of CRS, as it has nothing to do with IL-6, and the mechanism is really not well understood. There's some theoretical thoughts about CD19 expression and the blood-brain barrier, but right now it's still unknown. And because this is not mediated by IL-6, tocilizumab unfortunately does not work. So steroids are the mainstay of therapy. We get MRI brain to rule out cerebral edema. I'll mention that in a coming slide. Keppra prophylaxis is given because some patients have had seizures. And neurology is an integral part of this. They often recommend LPs or EEGs, infectious workup. So we really count on our neurology and neuro-oncology colleagues to help us manage this. There's this nice scoring system, which patients actually get very tired of. It's sort of like a modified mini mental exam. The one in my experience that patients hate the most is write a sentence. So they pick a sentence. They can pick whatever sentence they want on day 0 of their journey, and then they have to write it literally every day. And by day 14, they hate that sentence. They never want to say it again. So the rates of ICANS also differs between products, again, much higher with CD28 co-stimulation. And so on the left-hand panel is the ZUMA-1 with Axicell, much higher rates of ICANS than with Tisacel or Lisacel. Thankfully, the prophylactic steroids does seem to decrease the rate of this as well. And so in that cohort 6 study, the rates of grade 3 to 5 neurotoxicity dropped from 32% in the original ZUMA-1 to only 13%. So again, I usually quote my patients about 1 in 10 chance of getting very sick as long as we give them prophylaxis. One interesting article that was very recently published, which certainly not causative, and authors didn't claim it as such, but they associated hypophosphatemia with the development of ICANS. And this is such an easy thing to check and replete that I think it makes sense to do so. Again, who knows if there's actually a causation or if it's just a surrogate for something else, but worth repleting if you see hypophosphatemia. As an interesting subset of ICANS, with the BCMA-directed CAR T cell therapy, there's been an association with the development of a Parkinsonian-like syndrome. This is termed neurocognitive and hypokinetic movement disorders. It tends to come late, so in the months following infusion. It seems to be completely separate from either CRS or ICANS. There's some theoretical etiologies that it has to do with basal ganglia infiltration by the CAR T cells. Unclear why that would be with the BCMA CARs. And there's really no treatment for this. It can be progressive and it's generally irreversible. So this is one of the feared side effects, and there's really nothing we can do about it right now. Guillain-Barré has also been associated with BCMA CAR, and that seems to respond to IVIG. And I mentioned MRI a couple slides ago to rule out cerebral edema. This thankfully is something that has not panned out to be a major risk. On one of the original trials, the Juno trial, the JCAR15, there were 3 toxic deaths from cerebral edema. And this was attributed to high IL-15 levels. The trial was suspended, then restarted, and there were 2 additional deaths. And so the trial was completely discontinued. And Juno then switched gears and proceeded with a 41BB product. And that is now FDA approved. That's Lisa-cel. And I've never seen it with any of the currently approved products. It really just seems to be isolated to this trial. So thankfully not a huge issue, although nothing wrong with an MRI brain to be sure if somebody's developed neurotoxicity. One of the toxicities that most of the time won't be relevant in the hospital, this is more of the late effect that I'll see when I'm managing these patients months and even years after therapy, is profound B-cell aplasia and hypogammaglobulinemia. So this is an off-target on-tumor effect, as CD19 is expressed ubiquitously on B cells. And so I told you that these CAR T cells can persist for 10 years after, and so they're basically just ongoing destruction of any B cell. Has a lot of implications for vaccine response, especially in the COVID era. That's pretty important. The opposite of the B-cell aplasia is true for BCMA CAR, since that targets specifically the plasma cells. So you really lose all your plasma cells if you've got a BCMA CAR. The treatment for this, we just monitor immunoglobulin levels, give IVIG. It's somewhat controversial if you should give it prophylactically or wait until someone develops infections. And vaccination, remember, remains very controversial as well, as no one really knows what the right answer is in revaccinating from prior infections. And as a sad end to a really amazing story, Bill Ludwig, who was that first patient to be treated with CAR T, remained in remission for 11 years, was on IVIG, and unfortunately died of COVID-19 right before the vaccines were available in January of 2021. And COVID was a huge problem in CAR patients before the vaccines. Now, thankfully, most patients are getting vaccinated before CAR, and so they retain some protection. But when there was no vaccines, this was killing patients right and left after CAR T cell therapy. Another issue that comes up is prolonged cytopenias. This is a less well understood occurrence because theoretically, if it was just from the lymphodepleting chemotherapy, patients should recover, but sometimes they develop cytopenias months or years after. Sometimes their counts recover and then drop again. And so this may have something to do with the CAR cells doing something to the bone marrow environment, very uncertain. We treat this with growth factors, but patients remain at risk for infection. And the last one I'll mention, this is just to be a very proud husband. So my wife is a pediatric cardiologist, and she was at the Children's Hospital of Philadelphia. We were recruited here as a package deal. And she published for the first time in 2018 on the cardiac effects in pediatric patients who received CAR T cell therapy. This thankfully doesn't seem to be much of an issue in adults. It probably has something to do with the co-occurrence of ALL, Down syndrome, and cardiac abnormalities. But certainly nice to have a publication for my wife. Very proud of her. All right, so I've told you all about the benefits of CAR T cell therapy, why it's so exciting, and also about the side effects and what you need to look out for. And I want to move on now to telling you about what's coming to the University of Vermont. And we're almost there, although not there just yet. So when I started here, I had my work cut out for me and have spent my last 3 months really with meeting after meeting after meeting, getting us ready to roll out CAR T in the clinical setting, commercial setting. And so a lot of this was meeting with a variety of different stakeholders, including nursing, ICU, pharmacy, apheresis, pathology. We had a site audit in December, and we've gotten fully REMS trained. Now that we're in January, some education for house staff occurred earlier this week. I have an education session for nursing and ICU nursing next week. And actually, I'm sorry, in 2 weeks. And on January 30th, we have a dry run. This is where Kite, which is the company that we're going to be working with initially, is going to pretend that we have a patient. They're going to ship us a product that we're supposed to collect cells. We then send it back to them and they send it back to us. And we just sort of work out any kinks to make sure that when there's a real patient, we don't have anything go sour. If all goes as planned, which I'm hoping it will, by early February, we'll be activated as a site to treat patients. I've been asked a lot how many patients a year, and it's really hard to predict. We have some thought that it's going to be between 8 and 12 patients, at least initially in the first year. Again, the patients have to come, they have to be eligible, they have to show up. They might come in droves, they might not come at all, but my hope is that we'll be treating patients pretty actively on a regular basis. And this is from a patient perspective what they go through. So when you identify a patient as eligible, then get insurance authorization, and then you have to collect the T cells, which is done by apheresis. Very similar process to stem cell collection, although we collect T cells instead of stem cells. And then in the current world, we send those cells to a company to do the manufacture process. There has been a lot of interest in doing this as a homegrown product where if you have a lab that's set up for it, that's what was done initially at University of Pennsylvania. It allows for a lot of research opportunities if you can grow your own. We're not there yet, maybe someday. I've been discussing some with Ralph Budd and some of the immunology people about whether or not we might be set up for this down the road. But at least right now, we're going to be sending this to a pharmaceutical company to do the manufacture. The company will take the cells, they do the transfection with the lentiviral vector. They then expand the T cells, they package them up, and they ship them back to us. And that whole process takes between 2 and 3 weeks. Sometimes it depends on their slot availability, on how backed up their lab is. There's been some issues in the past where we may have an eligible patient, but there may be no manufacturer slot. But a lot of that is getting better, and so hopefully that won't be as much of an issue going forward. And unfortunately, since these are aggressive cancers, the patient often can't wait 2 to 3 weeks to get these cells back. So oftentimes we're giving bridging therapy, which is therapy really just to buy us time. If you get a great response, that's fantastic. And there are some centers where if you identify a CAR eligible patient, you give them, you freeze their cells and you give them bridging therapy, and then they magically get into a complete response. They do not give the CAR T cells. They decide that they're no longer eligible. That is very much not my practice. And the reason for that is that if you look at T cell expansion in patients who have no measurable disease at the time of their infusion, they still have an expansion, suggesting that there's some antigen recognition and going on. And it's very unlikely that patients are going to be cured by their bridging therapy. So we see no reason, or at Penn, we saw no reason not to give therapy to a patient in a complete remission, and certainly plenty of prolonged responses, even no measurable disease. So I think it's wrong not to give those cells if somebody's in a complete remission. In any event, that's relatively uncommon. Most of the time, these are aggressive refractory cancers, and they don't get into remission from bridging therapy. So once the cells are sent back to us, we give the patient a course of lymphodepleting chemotherapy. Patients ask a lot, what's the purpose of that? I've gotten so much chemo, it doesn't do anything for my cancer, but it actually has nothing to do with the cancer. It's much more akin to an allogeneic transplant where you're creating a space for the new T cells so that there's less competition, so they can just use up whatever resources they need and expand. And there has been some interesting data that lymphodepletion really is critical to this, that if you don't give adequate lymphodepletion, the T cell expansion is very poor. Still being worked out what the right doses are. Unfortunately, you can overdo it, and patients then have persistent cytopenias or risk for more infection. So there's a fine line there that we haven't quite worked out yet. There's also been fludarabine shortages. So fludarabine and cyclophosphamide are generally what's given as LD chemo, but the fludarabine shortage has made it very challenging. So as a substitute, bendamustine can be given. So I have a lot of experience giving bendamustine as lymphodepletion. And then the cells are reinfused. And a big question is, can this be done outpatient? Because historically, in the original clinical trials, most of this was done inpatient. I showed you how sick the patients can get, so it sort of makes sense to keep them under close observation, especially if you're using one of the CD28 molecules. But as we've gotten more experience, and especially with the prophylactic measures to keep patients not from getting so sick, it really seems quite reasonable to do this outpatient as long as they stay very close to home, very close to the center. And so why? Well, obviously reimbursement issues are a big problem with inpatient stays, the cost to the system, cost to the hospital. Inpatient capacity is a huge issue. I'm constantly trying to direct admit patients and being told we have no beds. And of course, patient quality of life. No one likes the food. No one likes to sleep in the hospital. So being either at home or Hope Lodge, which I'll mention in a minute, is a much nicer alternative as long as it's safe. And so the criteria to be outpatient that I imagine, so either a 4-1BB product or one of the CD28s with prophylactic dexamethasone, good performance status. Obviously, you don't want to have somebody who's, sort of borderline, might get really sick, might fall. You kind of want to keep them in the hospital. Arguably, if they don't have a good performance status, you're probably not going to be giving them CAR T anyway, but good to have a criteria. Low to moderate disease burden. So I didn't show this data, but it's been pretty clear that having a high disease burden, rapidly progressing disease predicts for severe toxicity. It sort of makes sense. The more antigen stimulation, the more the T cells will expand. So if somebody had a lot of disease, probably best to keep them inpatient. And then we want to keep them close. So even if they're outpatient, they're still basically living, right at the center. We're going to have a requirement of 30 minutes, and many patients are going to stay at Hope Lodge. And Hope Lodge is right across the street from the hospital. They can come in for labs as often as we need. They can come in to be seen in the office as often as we need. They could go straight to the emergency room if something happens. So it really does seem like a nice middle ground of safety, but also allowing patients to be out of the hospital. They also have to have a caregiver. I get asked this a lot by my patients, does somebody have to stay with me? And we really do require it because, if they wake up with a seizure at 2 a.m. in the morning, you really need somebody else there. And then the other question is, can you keep them outpatient if they initially were outpatient? So, day 4, somebody's getting this outpatient, they call in, they have a fever to 100.7. That doesn't necessarily mean you go straight to the emergency room, although early on it did. Now I really try to keep patients outpatient. You can give Tylenol outpatient. You can even give them low-dose steroids outpatient. If they need to get admitted, of course we will. But I think as we gain more experience with this, we'll really try to keep them outpatient unless they really need it. And then what's the future? So there is an extensive amount of research opportunity here, both with new products and with combination products. So I'll give you a little flavor of what's being studied elsewhere and what the future might hold. So new targets, CD19, BCMA are currently the only feasible targets, but that doesn't mean that there couldn't be other targets. There's a lot of interest in dual CARs, maybe something like CD19 and CD22 to get around some antigen escape that can cause relapse. Rapid manufacture time, 2 to 3 weeks is a long time if you have an aggressive lymphoma or leukemia. And so, 2-3 days is something that's been reported, though certainly not FDA approved. And then even better than a rapid manufacture time would be off the shelf. So there's allogeneic CAR T cells, CAR NK cells, which is a really interesting construct. NK cells don't have any issues with rejection. So, the allo CARs, there's some worry about, graft versus host, but NK cells don't have that, and they seem to just sit on the shelf just fine. And then bispecific T-cell engagers. So these are medications that sort of take the place of a CAR molecule. You grab onto a T cell and then grab onto the cancer cell and just pull them in proximity to each other. And then the T cell is activated and kills off the cancer cell. Another area of interest is CAR T cells plus other drugs that might sort of augment it. The one that makes sort of a lot of logical sense would be checkpoint inhibitors, but that has actually been pretty disappointing. So other medications that sort of deal with T cell exhaustion, that is a big problem, seem to hold more promise. So BTK inhibitors and IMiDs. There is some data for TIM3 inhibitors, with very early data. There's no TIM3 inhibitor that's approved for any malignancy, but that may mediate some of the resistance. And then other indications. So a CAR for Hodgkin lymphoma is absolutely needed. There's a CD30 CAR model that makes a lot of sense for Hodgkin, peripheral T-cell lymphoma, AML. And then what about solid tumors? So heme malignancies are obviously important to me. It's what I do, but I know that there's far more solid tumors out there than there are heme malignancies. And so how about one of these therapies for that? You can imagine a PSA CAR or HER2 CAR. Some of the toxicities might be limiting. And so as an early indication of that, TILs, tumor infiltrating lymphocytes, have recently taken the stage in advanced melanoma. And shown on the right here is a schema for TILs, a little bit different. A tumor is removed, and then you extract the T cells that are infiltrating that tumor and expand them, and then give them back to the patient with lymphodepletion in combination with high-dose IL-2. And this was recently reported, not yet FDA approved, but most likely is going to be. And though these aren't genetically modified, it's sort of still the same schema and will certainly fall into the cellular therapy space. And for everyone in the room who's not an oncologist, especially those of you who haven't been paying attention, checking your email or your Epic messages, what about uses outside oncology? So this is probably coming for all of you too. There's some really interesting publications about using CD19 CAR in lupus. Two, actually, one in the New England Journal of Medicine, one in Nature Medicine, both pretty recent. And I think these were highly refractory patients with lupus and, had dramatic benefit from a single treatment of CD19 CAR. There's also some data on CAR T, the treatment of cardiac fibrosis, something an article published in Nature a couple of years ago. So there's a good chance that this is teaching us ways to treat other diseases, not just oncology. So bringing CAR T to the University of Vermont has been a huge effort, and I really want to thank a number of different individuals. Dr. Holcomb for his unwavering support of this program and for recruiting me here. Chris Holmes, who's been really helpful in navigating the system since I'm new here. Hospital administrators have been very helpful in sort of overcoming a number of different hurdles and scheduling meeting after meeting after meeting. A lot of help from Rachel Rains with legal. Pathology blood bank personnel have been really helpful in developing SOPs, figuring out where these cells are going to be collected, where they're going to be, how they're going to be shipped. IT, especially in the wake of the cyber attack, has been really helpful. And then thank you for the future collaboration of all the people who are going to take care of these patients when they're admitted, when they're getting their cells. So nursing, ED, rapid response teams, ICU, house staff, neurology, apheresis, pharmacy, and of course, Hope Lodge. And then lastly, a huge thank you to our future patients who are going to be bearing the brunt of this and actually going through these therapies. So this is my last slide. I want to take you back as promised to my patient who in July of 2021 really had no other options and had pretty bulky disease, was in a really bad place. We enrolled her in a clinical trial using a new CAR T construct called HuCAR19 IL-18. And at her 3-month assessment, she was in a complete remission. And I spoke a couple days ago to the physician who took over her care after I left Penn. And over a year later, she's still in remission, living a wonderful life. So this really can be a transformative therapy for patients who otherwise wouldn't be with us anymore. And with that, I will take any questions.
Thank you, Dr. Gerson. I'll read a couple questions from online before handing microphones to all those in person. First question, are ferritin and CRP also elevated in ICANS?
Generally not. So if it co-occurs with CRS, then yes, but no, they're not useful surrogate markers.
And then do patients with germline mutations in cancer susceptibility genes have any different outcomes from this therapy?
I'm not aware of that ever having been looked at. It's a very interesting question.
And then Dr. Ladowski states potent immunomodulating treatments can cause hepatitis B reactivation in patients with prior hepatitis B exposure. Will hepatitis B testing be a part of the CAR T protocol at UVA?
Yes, absolutely. So there's actually a large number of infections that we look for prior to CAR T, and you can't have any of them. So, active Hep B, you can go on Hep B therapy. So the more common thing would be like a chronic latent Hep B, and definitely those patients would go on entecavir or tenofovir. EBV would be exclusionary, CMV. Actually, we learned a lot from COVID. So, in 2018, 2019, before COVID, we weren't really viral testing patients coming into the hospital to get CAR T, and a number of patients got severe CRS and then were found to have rhinovirus or adenovirus. And so then COVID happened. We started testing everybody for COVID, and we thought, well, why don't we just test them for all viruses? And so that's basically the new protocol, that you test them for all of these viruses right before their infusion. If they have anything positive, you have to delay their therapy.
Thank you. Questions from the audience?
Thanks so much. This is really great. So IL-6, really central pro-inflammatory cytokine, important in many chronic diseases. And it's involved in glucose homeostasis and obviously inflammation and coagulation activation. Do these patients with cytokine release get glucose disorders or thrombotic manifestations, arterial or venous?
So glucose disorders, I think not uncommonly because of the steroids. It would be very difficult to parse out which is which, because I don't think any patient would get TOSI without being on Dex. And, so their sugars are going to go crazy, especially if they have diabetes. So I doubt that would be possible to look at because you'd always be on both. The clots, certainly some patients have developed clots. These are cancer patients who are at high risk. If they're hospitalized, they're immobile. But I don't think there's been necessarily a significant increase in incidence in clots. Just what you'd expect from a hospitalized patient who has cancer. No triggered MIs, no.
So I'm really intrigued about the report about CAR T potentially being useful for cardiac fibrosis. And so I'm wondering if there's been any consideration for investigating whether CAR T therapy might be useful for patients with hepatic fibrosis, which is obviously a huge problem in patients with fatty liver disease progressing on to hepatocellular carcinoma, and whether this might be able to arrest that progression.
So I'm not aware of anything in hepatic fibrosis. The cardiac fibrosis is a different target. It's not CD19. And it does, sort of raise the issue of what the target is in any non-malignant condition you're going after. I think the thought in the cardiac fibrosis is targeting the macrophages that are sort of mediating the fibrosis or maybe the fibroblasts. So it's not a CD19 target, and it's a very interesting idea to think about liver fibrosis as well, but I'm not aware of anything.
That was a great talk. Thank you. It's very exciting. Any concern that tocilizumab or steroids might increase the risk of relapse, or is that not seen at all?
Yeah, no, absolutely. So I mentioned early on in 2018, 2019, we were really worried about that. And that's why we let patients get really sick and we only used it as a last resort. So, somebody would be in the unit, 5 days of fever to 106, and then we'd say, all right, fine, let's give them Toci. The cohort 6 of the Zuma 1 trial, their outcomes were superimposable on the regular cohort, the non-cohort 6. And so if outcomes really are the same and there's no higher relapse in the early use of these medications, I don't think that there's any impact. There's been a lot of retrospective. It's obviously not randomized. It'd be very difficult to do a randomized trial where you reserve Toci for somebody who's really sick versus give it when they're not so sick, to really look. And that'd be the only way to really answer the question. But at least retrospectively, it does seem like it doesn't impact relapse rate.
And a second question, if I may, do we see any of the long-term side effects like we see with sort of bone marrow transplant, like sort of, the pulmonary toxicity, the skin tox? No.
Yeah, great question. Yeah, not at all. The main long-term side effects are the B-cell aplasia and the low immunoglobulin levels.
You alluded to it being early days and it being difficult to do the manufacture locally, but do sites with the number of prognosticated patients and our resources do the manufacture the CAR T cells locally typically?
Yeah, so only in a research setting. So these constructs are FDA approved as produced by the company. That patient that I showed the picture of in my last slide, that was a homegrown product, in Carl June's lab. That's sort of his next generation CAR is this IL-18 CAR. So on a research protocol, absolutely, you can, treat anybody you want, I guess, as long as you get FDA approval. But commercially, no, it has to be done through the company. Yeah, great. So to determine eligibility for CAR T, you have to have a baseline echo and pulmonary function test. And we have criteria. You basically can't have heart failure. It's not a requirement by the FDA. It's more of an institutional policy. So, a 25-year-old who had anthracycline-induced cardiomyopathy with an EF 35% and CAR T was the only option they were willing to take the risk, we could certainly decide to treat them. It's not like anyone's telling us that we can't. But as an institutional policy, these patients are all going to ideally have good cardiac function and good lung function. With that, I personally have not seen any cardiomyopathies or lung fibrosis as a result of CAR T. You could think that if somebody got severe cytokine release syndrome, they might have like a Takotsubo, stress-induced cardiomyopathy. So I think uncommon, but it's theoretically possible. My wife's publication was looking at patients who had pre-existing congenital cardiac disease and showed that they had an increased risk of cardiac toxicity, which makes a lot of sense. But again, since a lot of them are Down syndrome patients who are at risk for ALL and like tetralogy of Fallot, we don't have that in an adult population. So the risk is much, much lower.
About the slide. Better. Is there like, because I'm asking people stop that big with that but the next
Yeah, no, great question. And for many patients, it burns out on its own. So, if it did not, if all patients required TOSI, then we would never do it outpatient because we knew everyone was going to need TOSI. So, like somebody might develop a fever to 101 for a day or two, and then it just resolves with Tylenol. Some patients, it goes from 101 to 102 to 106, and then, they get admitted. So it certainly can burn out for most patients. It actually burns out on its own. There was also some thought initially that you like to see some CRS because that means the T cells are expanding and that they're going to have a response. But it's been shown that there's really no relationship, that you can have no CRS at all and still get into remission.
Thank you very much for your talk. Just a question, since I don't know much about the therapy. I mean, when you don't have a response, is it a lack of expansion? Is it exhaustion? And are you all checking the T cells for things like LAG3, TIM3, IL-10 receptor, things like that before you're putting them back in?
Yeah, great question. So on the Juliet trial, which I know pretty well because that was the Penn's trial, they were checking qPCR to look for the transcript of the CD19 directed CAR cells routinely. So, at various time points, immediately after infusion and for months after. And that's how we know that there's persistence for years after. But unfortunately, that qPCR test is not FDA approved. It's not like CLIA certified. It's just a research test and it's very expensive. So you can really only do it on a research protocol. So commercially, we have no ability to tell what the T cells are doing. We, sort of guess that if you have a nice response, you did expand. And if you don't have a nice response, maybe they didn't. And the mediators of relapse are either lack of T cell expansion. So certainly some patients just have no expansion at all. The cells just dwindle out and die. Some patients develop CD19 negative relapse. That's more common in a leukemia setting. We don't quite understand why, but most of the lymphomas, when they relapse or are refractory, they retain CD19. So that's probably more of a T cell exhaustion phenomenon. And so TIM3 and it's LAG4, I think, right? Those have both been implicated as sort of markers of T cell exhaustion. And, it was initially thought that PD-1 might be a really great way to sort of stimulate these T cells, but it doesn't work. I mean, the response, so if you get CAR and relapse, have early relapse and then get Pembro, the response rate was like 10%, something like that. So very, very low. I mean, possibly, but very low. But there is some thought that the TIM3 and LAG4 may actually play more of a role.
Thanks very much.
Thank you, Dr. Gerson. Great talk, always. Quick question. You mentioned about hypophosphatemia or increased risk of neurotoxicity. Just curious if those patients received IV iron or those transfusions prior to receiving their CAR T, because we know that some of the iron products can cause hypophosphatemia and others. So just curious if that's playing a role.
I'm not aware. They didn't report that in the study. I guess it's possible they just didn't mention it, but I don't think that was a central part of it. No.
All right, well, thank you, everyone. Thanks, Dr. Gerson, for a great talk.